This is visible.
Very good afternoon. My name is Aniruddha Agarwal, and I'm at the Cleveland Clinic, Abu Dhabi. At the outset, I would like to thank the Scientific Committee of All India Ophthalmic Society for this opportunity to present my talk on OCT and OCTA in uveitis. Imaging in uveitis is such a broad concept, and in the next 8 minutes, I would like to cover a few entities in uveitis that we commonly analyze using OCT and OCT angiography. White dot syndromes consisting of serpiginous choroiditis and multifocal choroiditis are the most important and common entities that we encounter and can be assessed using these imaging tools. The other entities such as punctate inner-choroidopathy and MUDES are not so commonly encountered in our subcontinent. This is a classic case of a young male with bilateral diminution of vision, and as you can see, there is serpiginous choroiditis because of TB, and you have the classic yellowish serpentine lesions on the fundus in the macula, and autofluorescence imaging shows you that these lesions are hyperautofluorescent, which means that they are active. The right eye also has lesions, especially involving the fovea and vision-threatening lesions, which are active and hyperautofluorescent. In these patients, when we perform a combined fluorescein and indocyanine green angiography, we realize that on fluorescein angiography, some of the macular lesions may be difficult to detect in the early phase, and there is leakage from the lesions. And ICG angiography is very useful in delineating the choroiditis and the involvement of the choriocapillaries. And it appears as hypofluorescence on ICG, indicating that the choriocapillaries flow is compromised. This is a blown up picture of ICG, and as you can see that this exactly correlates with the OCT angiography image, and you can see that the lesions of choriocapillaries are so clearly demarcated on OCTA imaging. When OCTA was initially launched a few years ago, this was a very useful entity because on OCTA we could confirm the presence of choriocapillaritis and inner ischemia of the choroid, and there was exact correspondence to ICGA. And we published these findings in the Journal of Retina in 2017. Subsequently, we realized that when you do a follow-up imaging in these patients, ICG imaging shows you a near complete resolution of the choriocapillaries hypoperfusion. As you can see, it's not very easy to perform a repeat fluorescein and ICG for all our patients. And therefore, when you compare the ICG, it's a great thing to have to see the choriocapillaries recover. But you can also do this non-invasively on OCT angiography. And you can see that there is near complete resolution of the choriocapillaries flow except for some disturbance in the center of the lesion. So this is a very important learning lesson for us, that healing of choroiditis lesions is accompanied by reduction in the choriocapillaries flow deficit area. And we realize that if the lesion itself is less than 0.1 millimeter square in size, they tend to resolve with minimum flow void areas. And this was subsequently published in 21 April issue of Retina journal this year. And as you can see that you can have a very good follow-up imaging using OCT angiography in patients with choroiditis. Placoid lesions can also be imaged using OCT angiography, and you can see, as if you focus on the panel towards the right, you can see that the edges of the lesion which appear hypo-reflective on OCT angiography, they tend to resolve on the follow-up imaging, which is down at the bottom on the right. And this indicates that the choriocapillaries have recovered, although there is central choriocapillaries atrophy, and you can see the underlying choroidal vessels. This is a patient who has a classic appearance of AP-MPPE on ICG imaging. And as you can see, there is ellipsoid zone disruption, photoreceptor disruption, and a large placoid lesion. And as you can see, the ICG correlates exactly very well with the OCT angiography imaging, very much like choroiditis lesions. So the pattern of choriocapillaries flow deficit exactly matches with the ICG, and you can use the OCT angiography to monitor these patients. This is our learning lesson number 2. VKH is a very commonly encountered disease. And as you can see, this is a classic textbook picture patient where you have choroidal granulomas imaged using ICG imaging, and you have on fluorescein multifocal pockets of serous retinal detachment. Now, when you do an OCT, and this is a recent description from our group, that these patients have what is called as the bacillary layer detachment. Essentially, if you focus on the image number B, you realize that the arrow, which is termed as BLD, is the bacillary layer. It simply indicates a split in the myoid zone of photoreceptors. And as you can see at the bottom of this hyporeflective space, you have the ellipsoid zone, which is relatively intact. This has been termed as the bacillary layer detachment. And this, if you look at the figure D, separates a serous retinal detachment, that is SRD, from intraretinal fluid. Now, this is not something which is new because compartmentalization of fluid was always known to happen in VKH, and only now we are calling it as bacillary layer detachment. The main utility of this sign is that it indicates presence of an underlying inflammatory pathology. And this is something that you will not see commonly at all in CSC patients or other patients who have non-inflammatory causes of serous retinal detachment. And this was subsequently published. Finally, I would like to talk about utility of OCT and other imaging tools in distinguishing between choroidal granulomas. Now, granulomas of the choroid, including TB and sarcoid, present a diagnostic challenge. And so in these patients, it's very useful to have, in addition to lab help with multimodal imaging. If you see this particular OCT, you see a very large choroidal granuloma, which is causing a bump and elevation of the RPE. This is a patient who has TB choroidal granuloma. And one of the very useful ways to identify this is by the presence of this oblong or a very large choroidal granuloma filling almost the entire choroidal space. And if you see the first figure on the left, you have this fuzzy infiltration of the outer retina. This is a very common feature of TB, where you have fuzzy infiltration of the retina. And as you can see that the arrows are pointing towards the infiltration of the retina at the bottom below. This outer infiltration can differentiate TB from sarcoidosis. And in fact, this has a very strong p-value. And TB choroidal granulomas have characteristic outer retinal involvement, which is not seen in sarcoid. This is a patient who has sarcoidosis. Now, in the lesions which are sarcoidosis, they have very small choroidal granulomas. And these patients tend to have a rounded lesions without much overlying fluid or exudation. This is in contrast to patients of TB that we just saw. And therefore, OCT is very useful in detecting these lesions of choroiditis and distinguishing between the etiology. Of course, they do not replace the lab evaluation, but it's very useful for us to have OCT imaging in order to aid the diagnosis. With this, I'd like to thank everyone for your attention. I'm happy to take any questions.